So we're here to take a moment to look at the shoulder girdle and look at the shoulder itself in a seated position. We're using this to show you what this might look like, such as a patient may present in a way that we need to work on the arm, we need to work on the shoulder, however, we're not able to have them take a position other than seated. One of the reasons that I want to show this is because we can also deal with the concepts of patient positioning and how when we can't get what we want, we still have to try to make an appropriate treatment approach work. So if we're looking at patient positioning, we want to consider that the table makes stable, so that if a person can be in more contact with the table, they are more stable, they're safer. If we can't have that, less stable means I need to make the patient more stable. Now when a patient's in seated, if I'm going to make them more stable, the easiest way to do that is to use my torso. So often I would be positioned behind the patient, but we want to consider making sure that the anatomy is free to move in all planes required and preferably visible. Now, in a situation like this, often I may work behind the patient, but I want to work in front of the patient so that you can see some of the ways that you may deal with this or some of the challenges you may encounter. So if we just consider moving the scapula from here, right? I'm pretty far away and I want to move the scapula, right? I'm going to have a hard time because I'm just going to wiggle the patient, right? Now, if I just slide your legs over that way, there we go. If I can now use the arm as a lever, right? Now if I'm just here and, loose control of the arm, I might be able to work on the scapula, but if I'm not using my eyes, I won't see that I'm just dragging the patient around. Now if we consider controlling a patient's body or controlling somebody's body and other areas where we would see this is an arm drag. Right? This is essentially an arm drag takedown or a way to control somebody in a grappling match. So I'm going to use the general concepts of using the arm to control somebody, but I'm going to use another concept of ours. Contact is control and control is safety. So I want to be able to control off of a lever because I can't quite get to the anatomy that I want if I'm looking at the shoulder blade itself. But I've got good contact, so a wrapping and reinforcing hold. I've got the ability to reach here now, and I can do some glides. Now, again, you see me rocking the patient around. So what's a way that I can make myself get closer to the patient so I can then have more control? Well, I can come up onto the table and get even closer. Now, you'll see that I can use my forearm, I can use more contact off of my arm to begin to control the patient. And you won't see this, but I can sneak my arm or my hand further into the patient's axilla. Now I can do some gliding, right? I can do some gliding of the scapula without moving the patient as much. Now another thing that I can do is I can put the scapula where I would like it, and I can say, I would like you to twist to your left, just gently. Twist your whole body to the left, okay? And let go, or come back rather. Twist your body to the right, okay? And then relax. Tuck your chin to your chest and roll your body forwards. Okay, and then look up at the ceiling and stick your tummy forwards. There we go, and relax. So now what we have is me removing my need to control the patient, but holding the scapula still and having the patient move in relation to a relatively still scapula. So we talk about the idea that I can come in closer, right? I can control the lever. If I come up closer to the lever and I hold on in the region of the axilla, right, or kind of wrap around the humerus, and then I contact, lots of contact here, using my forearm, now I can wrap around the scapula. If I move, right, if I'm not careful when I'm doing this, I'm running into moving the patient around. So if I want to move the scapula in relation to the patient, I can do this. Or I can hold the scapula still and move the patient in relation to the scapula. So you can see that that idea of less stable means I need to make the patient more stable causes me some challenges. So a creative way around that could be holding the anatomy that you want to work on still while the patient moves in relation to that thing, right? If we want to talk about the shoulder itself or the GH joint, right? What we can do here, it's a little bit easier because now we're essentially creating a disassociation between the humerus and the scapula. Not necessarily disassociation in the sense that I'm creating a dislocation, but more so that what I'm trying to move is the humerus in relation to a relatively still scapula, which means that the patient can just be restful. So I have the same kind of hold, right? So the same kind of wrapping and reinforcing hold, wrapping around the humerus, or wrapping really, in this case, around the forearm, controlling the humerus, and then I can use my palpation hand to create palpation and a fixed point. So broad point for multi-point discrimination also turns into a nice broad hold around essentially the clavicle and the scapula. I can keep those still and still palpate, right? Then I can also create glides, should I need to. Now, let's just say I need to create shoulder flexion. I'm not gonna do it this way, right? The limiting factor here happens to be me. My body's in the way because I'm trying to control his arm. Now, in this case, for good contact, I can put the patient's arm on my shoulder so I can create shoulder flexion, and then I can use two hands in and around the actual GH joint, right? So now it's okay if I move the patient, because what I'm trying to do is create that motion. So, you know, the idea of relational motion, one thing stays still, one thing moves in relation to it, or two things move in opposing directions with respect to one another, right? So I can kind of wiggle the patient around here, and this actually gives me some interesting stuff at the GH joint, but it's kind of a quirk where usually this is not what I would want. I would not want my patient moving like this in many cases, but in this case, it's not that bad a deal. I can then turn this from a patient passive approach to a patient active approach. Just kind of tuck your chin to your chest and roll forwards. Good. There you go, and relax. So look up the ceiling and stick your tummy forwards, right? There you go, right? So again, I've got this. Now in this case, what you do is you try different approaches. So the patient active approach actually didn't give me as much control of the shoulder as I would want. But this, you know, allows me to do some interesting things. Now, as long as the patient can relax well enough and they trust me enough and I don't make any extraordinarily large moves that make the patient feel like they're going to fall, they can stay relaxed enough and I can get some pretty interesting stuff to happen at the GH joint there. But those are things you have to consider. Our concepts of patient positioning being that the patient, or the table makes the patient stable, less table means I need to make the patient stable. Those are there to help you understand that there are normal responses to motion, especially with a person that you don't know particularly well, taking over motion for you in a patient passive situation, that makes it good for a patient to have a response where they don't relax, where they essentially tense up. It's a safety thing. If, again, I'm working with the patient's arm above me and a good hold around the whole GH joint, they have to feel safe enough. So I have to move in a way that doesn't scare them, and I can't move them so fast that they have to brace themselves, okay? It's going to take some trust. This will not work for a lot of people. You would probably be better off doing more of your individual GH joint work in either lateral recumbent or in supine, because the patient is going to be better controlled and you're not going to have to wiggle their body and their arm. That's to show you an option for working in and around the scapula, in and around the GH joint, and how you take these concepts and relate them or put them together, string them together to overcome some of the problems that you're going to run into when you can't use the patient positioning concepts in their ideal sense, when you have to make do, right? You still try to get more contact for more control. You still try to use patient active where reasonable. You still try to use the relational motion concept where one thing stays still and one thing moves in relation to it. So do I keep the shoulder blade still and move the patient's body? Do I try to keep the patient still, which is very difficult to do, and move the shoulder girdle or the shoulder blade? What do I do? Well, I can test it out and I can figure it out, but we've just shown you what it looks like to try to figure that out, and then some base concepts, base holds that you may have some success with, keeping in mind that you are still considering it's difficult to keep the patient relaxed enough, because they should tense up when they're out of control or when they don't have as much control and they don't know if you have that control, which is again why our concepts of patient positioning, the table makes stable, less table means I need to make the patient stable, space between us is unstable, and then how I would want to position with respect to being able to see what I want to work on. All of those things come into play to try to overcome the normal, healthy responses of a patient tensing up in relation to what you're doing. So again, that's one of the ways, or those are examples of the ways that you can deal with that with specific relation to the shoulder girdle and the GH joint itself. Those are not the only ways, but those are some ways.